My name is Pam Hunter, Assembly Member from the great state of New York, chairing our NCOIL Health Insurance and Long-Term Care Issues Committee. We are going to get started. We have a full agenda this morning, so I'd ask for a motion to waive the quorum, please. A second?
Second.
All in favor?
Aye.
Opposed? Abstentions? Ayes have it. Ask for a motion to approve the July 14, 2022 committee meeting minutes, please. Second.
Second.
All in favor?
Aye.
Opposed? Abstentions? Okay. We are introducing and discussing our NCOIL Biomarker Testing Insurance Coverage Model Act. I am a sponsor, the proud sponsor of this bill. I have this introduced in the state of New York as well. A copy of the model appears in your binder on page 33. For those following along, it's on the website and the app as well. For those of you who were at the summer meeting in Jersey City this past July, you may remember we had a general session dedicated to this topic. That session was a great opportunity to learn more about the issue before developing a model. And I'm looking forward to discussing the actual model today and hearing everyone's thoughts about how it may be improved. Similar legislation has been either introduced or signed into law in states such as Arizona, California, and Illinois. Again, I've introduced this model in New York. One last thing before we get started. This model will not be voted on today. We are still in the development and information gathering phase. So depending on how things go today, we may be voting on this model during our next meeting in March. So we're going to go ahead and get started. We have Dr. Mark Matrana. He is the Director of Precision Cancer Therapies Research Program and Associate Director of Clinical Cancer Research at the Ochsner Cancer Institute. We have Tammy Middleton, a volunteer at the Go-To Foundation for Lung Cancer, and James Galfin, President of the ERISA Industry Committee, and I believe Hillary Geckner from the Cancer Society will be at the table as well. We will hold all questions until the end of the presentation. So, Dr. Matrana, please.
Great, thank you very much. And I believe I have some slides. Hopefully we can get those loaded. Let's see.
We'll get those loaded if you want to go ahead and get started.
Okay. All right, well, I'm Mark Matrana. I'm a practicing medical oncologist. I see cancer patients every day, and I also direct precision medicine at Ochsner Health, which is the Gulf South's largest health system. I've been instrumental in passing legislation here in Louisiana around comprehensive biomarker testing and precision medicine in general. We've actually passed about half a dozen laws to really protect cancer patients, the interests of cancer patients, make cancer care safer, cheaper, and better for our patients all around. Hopefully we can get the slides up. But really, the question is, what is biomarker testing? What do we mean by biomarkers?
Could you bring the microphone closer? There's
Sure.
a lot of people in the room. Thank you.
Sure, absolutely. So what are biomarkers? What do we mean by biomarkers? Well, at the most broadest level, a biomarker is anything we can measure in the body to help us make a better decision for a patient. But when we're specifically talking about cancer, the biomarkers that we often use are things like genes. So we can sequence a gene and it can tell us if a cancer patient will respond better to drug A or drug B. This is not some new experimental thing. This is actually standard of care. If I don't do this testing and if I don't prescribe the right drug for the patient, my patient's going to have a far worse outcome. In fact, they're going to have a shorter life expectancy. I'll probably get sued for malpractice, or I certainly should. But the problem is that not every insurance company is paying for guideline-based, proven, comprehensive biomarker panels. And this is unfortunate because patients really need this. In the state of Louisiana, through the Cancer Advocacy Group of Louisiana, we were able to successfully pass a number of bills that guarantee that our patients will have access to this type of testing. Yeah, just to give you a few examples, lung cancer. You're going to hear about this from one of our patients, our Louisiana patients here today. But there are 14 different genes that we know of today that drive lung cancer. Most of those are associated with a therapy. And if you get on the right therapy for the gene that's driving your lung cancer, you're going to have a far better outcome. You're going to be able to go to work and be a productive member of society rather than having to take chemotherapy. You're going to live far longer, maybe a decade longer than counterparts who don't have those same mutations and are never got tested for them, are not on the right therapy. And so, you know, the biomarker testing that we are proposing, the legislation that we are proposing here, is not to prove anything that's experimental. It's not to prove anything that's not proven. It's to simply approve guideline-based testing that's going to save lives and at the same time save a lot of money, and I mean a lot of money. In 2003, it cost $2.7 billion to sequence the first human genome. Want to guess what it costs today? $200. It took 13 years to sequence the first human genome. I can do it in a couple of days with a machine that's about the size of a small fax machine or a small printer. We've made dramatic improvements in the cost of these testing, in the cost of the testing. And by getting the testing for patients, we're then able to put them on better, more effective therapies. They're able to go to work every day, to pay taxes every day, to be productive members of society. We no longer have them sitting in hospitals, dying of their cancer. It saves vast amounts of money when we get the correct testing and we get the patient on the right therapy. I'm sorry I didn't have the slides for you today, but really that's the point I wanted to bring across. There they are. Let's see if I missed anything. We talked about what biomarkers are. We talked about how rapidly genomic medicine is coming into play, not only in cancer, but across all of medicine. You know, I told the CEO of our hospital just a couple of weeks ago, I said, we're not going to call precision medicine in a few years. We're just going to call it medicine, because that's what it is. You know, every one of us are our genes. And once we really uncover this in a big way, this will be the basis of all medicine. We talked about why legislation is needed. As you mentioned, Chairman, Arizona, Illinois, Louisiana, Rhode Island already passed these bills, and they're being considered in other states as well. And so this is, I love this cartoon here because it really explains what we're talking about. We can make decisions based on genetic information that can tell us, you know, does our patient need a standard dose of drug? Does he need half a dose, a double dose, or does he need a completely different drug? Before, we were shooting in the dark. Try this. Take 2 aspirin and call me in the morning. I hope it works. Maybe it won't, and then we'll try something else. Now I can take a tube of blood and within days have an answer of exactly what will work for each patient. Again, what won't this legislation do? It won't require unnecessary, unproven tests. It's going to tie coverage to FDA-approved and cleared tests, things that are clearly labeled and indicated for these tests. It's going to tie this to CMS coverage determinations and nationally recognized, scientifically sound practice guidelines that are written by really the best physicians America has. And again, it won't increase cost. It simply won't. It will save a lot of money across the board. That's all. Thank you very much. I appreciate it.
Tammy?
Thank you for the opportunity to tell my story and advocate on behalf of other patients. My name is Tammy Middleton. I'm a lung cancer survivor from Alexandria, Louisiana, and a volunteer with the GoTo Foundation.
Tammy, can you pull the mic closer, please?
Yes.
Thank you.
Is that better? Okay. In December of 2018, a CT scan showed a large tumor in my left lung during an ER visit. It was suspected to be lung cancer. At that time, I chose to go to MD Anderson in Houston, Texas, for additional treatment and diagnosis. In the beginning, I had 2 tissue biopsies that failed to identify my type of cancer one from my right adrenal gland and one from my left lung. My oncologist decided to pursue next-generation sequencing biomarker testing on a liquid biopsy of my blood. This confirmed a diagnosis of stage 4 ALK-positive non-small cell lung cancer. Based on this diagnosis, I was immediately started on a course of radiation and a targeted therapy developed specifically to treat ALK-positive lung cancer. Treatment started a month after the initial tumor was found. Soon after starting targeted therapy, my health began to improve. I was stable until April of 2021, when a new spot appeared on the right adrenal gland. Again, I had another tissue biopsy that did not yield any actionable information. My oncologist pushed to do another set of next-generation sequencing biomarker testing on another liquid biopsy. This revealed that there had been no additional mutation burdens, and we could locally treat the new spot with radiation. That meant I could stay on the targeted therapy that I had been on for 2 years at that point. After that round of radiation, I've continued to be stable for a total of 3 years and 9 months. This is all on the same initial treatment that I started with in January of 2019. Next generation NGS biomarker testing allowed my cancer to be diagnosed quickly so that I could start treatment with a protocol that is effective for ALK-positive lung cancer. In April of 2021, NGS biomarker testing guided treatment decisions that has allowed me to continue on my original therapy, rather than hopping from one treatment to another. This buys me time for research to happen, cures to be found, and it gives me hope. It also keeps other treatment options on the table for me in the future. Access to the information from comprehensive biomarker testing allows me and my oncologist to always make the best decisions for my treatment. As an example, because of the specific genetics of my cancer, we knew that immunotherapy, which is a powerful treatment for lung cancer, would have zero effect on my cancer. On this journey, I've discovered that access to good cancer care is a roll of the dice. I have been fortunate to access care at a center with the resources to fight for me to get the right testing and the treatment that I need. That is not the case for every patient. Cancer care should not be a roll of the dice. All patients should have access to the testing needed to best direct their care. On their behalf, I advocate for other patients to have access to the same testing I've had and they need.
Thank you, Tammy, for sharing your story. Thank you. James?
Is it on now? Perfect. Okay, great. Thank you for the opportunity to participate today. I'm James Gelfin, president of the ERISA Industry Committee, or ERIC for short. ERIC is a national trade association that represents Fortune 100 employers on benefits issues. Our large employer member companies sponsor health insurance benefits for tens of millions of Americans all across the country. Our members primarily offer self-insured plans, where ultimately the employer is on the hook for the costs of health care for our employees, their families, and retirees as well. Some of our members also offer fully insured options to some or all of their beneficiaries. In all of these cases, the benefits are designed to maximize value for beneficiaries. We are fiduciaries to these plans, and we have a duty to design and implement health insurance benefits that provide high-quality care, that meet the needs of our beneficiaries, and that do so in a way that is value-driven and responsibly spends plan funds. Overall, ERIC members pay about 85% of healthcare costs on behalf of our beneficiaries, and it's widely acknowledged that employer-sponsored benefits are the most comprehensive and generous coverage generally available. Health insurance is a voluntary benefit that employers offer to attract, retain, and support employees. Between 160 and 180 million Americans get their health insurance through a job, and 110 million of those get their health insurance through a self-insured plan. For large employers, they could instead choose to pay a fee under the Affordable Care Act The fee is $2,500 per person, which is much, much less than what the average cost is to actually insure our employees. For small employers with fewer than 50 employees, there's no penalty for dropping insurance. And as costs continue to rise, small businesses are dropping coverage, and their employees and their families end up either on taxpayer-subsidized ACA plans, on Medicaid, or uninsured. But employers do want to offer coverage, and most small and medium-sized employers would prefer to buy fully insured state-regulated plans because it's the most simple arrangement. They pay the insurance company, and their employees are taken care of. However, many of these companies opt for self-insured ERISA plans, mostly to escape the extremely high costs of state-mandated coverage rules. I used to work for a U.S. Senator from Maine, and at the time, Maine was one of the states with the most health benefit mandates in the country. As a result, we had chased away all but one insurance company. The costs of insurance were ludicrously high. The individual and small group markets were basically dead in our state. After the ACA passed, Maine reduced some of these burdens to bring the market back, and indeed, many states are now cognizant of the need to allow flexibility in coverage. But many state legislators are frustrated at their inability to regulate self-insured plans. At the same time, they propose and pass laws that push more people into self-insured coverage. I know that there are state advocacy groups that have a grand vision of eliminating ERISA preemption for some or all health plans, but this would be strongly opposed by many stakeholders in D.C. So until that happens, legislators and regulators who want to keep control over health benefits in the state might consider how increasing mandates and therefore increasing costs could lead to fewer covered lives within the state's purview. Let's talk for a minute about those costs and the cost of health insurance, which stem directly from the higher costs of health care that is delivered. Those costs continue to grow. They've devoured the wages of working families, putting more and more pressure on both workers and employers. I remember over a decade ago when we were all shocked that General Motors was spending more money per vehicle sold on health care than they were on steel. Then I remember being shocked again several years later when the Kaiser Family Foundation confirmed that health insurance now costs the average family in a given year more than the cost of a motor vehicle. And no doubt this year or next, a new statistic will come out that shocks us further. Most of these unsustainable costs increases are attributable to hospital costs, some to drug costs, some to paying providers, some to middlemen and administrative entities. But the thing to keep in mind is, as healthcare costs expand to take up a greater and greater share of the economy, the healthcare industry is making more and more money while families are forced to face those consequences. Eventually, if we continue down the path of ever-increasing healthcare costs without finding a way to rein them in, we will end up with something akin to Medicare for all because employers will not be able to continue to sponsor plans. On the specific subject of mandating coverage for biomarker testing, Eric believes that this mandate would likely increase costs, would drive waste in the healthcare system, and would further enrich the medical-industrial complex without really benefiting patients. We appreciate that there are members of NCOIL who see the great promise in biomarker testing, and we see that promise too. But mandating coverage will actually move us in the wrong direction. And don't take it from me. Take it from the California Health Benefits Review Program at UC Berkeley. They wrote, under existing law, plans and policies are required to cover medically necessary diagnostic lab services and ongoing disease management services. Additionally, biomarker testing is broadly covered by California's EHB benchmark plan. They further wrote, broadly speaking, all enrollees with health insurance subject to a proposed bill in California have coverage for biomarker testing that is supported by medical and scientific evidence and is determined medically necessary. In other words, when biomarker tests are useful, and that is when they provide accurate and actionable information for patients and providers, those tests are already covered. They may be covered due to existing laws, such as the Affordable Care Act's essential health benefits requirements, or they may be covered under ERISA plans because they're medically necessary, they provide clinically useful information, and that information leads to better and more efficient care. Both employers and health insurers want better and more efficient care. They can save money by providing effective treatment sooner, by avoiding treatments that would harm patients or would be a waste of time and money, and by ensuring optimal care that can often stave off more serious and expensive interventions later. They can learn in advance what problems are likely to arise and address them in the plan of care prior to those problems metastasizing. Employers and insurers make these kinds of investments all the time, and they do so voluntarily because it's the best way to drive value in the health plan or insurance coverage. But the model legislation proposed would broadly require insurance to cover biomarker testing when the testing is supported by medical and scientific evidence, which is defined to mean that the test is FDA approved, developed to inform pursuant to an FDA approved drug, is covered by Medicare, or is supported by a national provider group or multi-stakeholder group. Basically, this means that the test works. It doesn't mean that the test is actually useful. For a test to be useful, the patient and provider would need to learn actionable information. If you got a certain result from this test, what would you change in the course of treatment or the care plan? And if the answer is that something would in fact be changed, then the test is likely already covered under current law and best practices. That sounds like a test that's medically necessary. It's needed for a provider and a patient to make a consequential choice about care. So under current law and policy, when might a biomarker test not be covered today? Well, going back to the California analysis, they projected that if the mandate was enacted, the primary change would be that tests would be conducted more often when they weren't really called for. They described this as tests used for screening purposes rather than tests that would be due to indications and lead to clinical responses. They projected that the use of biomarker testing would increase at about $1,000 a pop, but that it wouldn't likely improve health. Reading between the lines, they anticipated that providers would start ordering more of these tests in order to obtain information that wasn't actually useful or actionable. But of course, the providers would now be reimbursed for ordering those tests. So they would make more money, but the patients and the employers would pay that money, and health would not necessarily be improved. I don't need to tell you that a lot of tests on the market today are deeply problematic. Worse than just not being useful, many tests provide information that is unreliable. These tests are causing patients to make drastic and incorrect choices about their health care. They're scaring patients. They're charging thousands of dollars in order to tell patients something that may be wrong or misleading. In my previous role working for a patient advocacy group, we were extremely concerned about certain genetic tests that were being pushed by for-profit companies. Those tests were providing questionable results to patients. Patients were then acting on those test results, making decisions that would have long-term and drastic effects, particularly on their fertility, their biomes, and their overall health. At the time, we advocated that test results from these genetic tests should always be put into context and should always come with counseling from an expert and should fully disclose in a way that was comprehensible to those with low health literacy their potential to be inaccurate. And I can't imagine mandating that insurance pay for those tests, which would result in many more of those tests being delivered, especially knowing how it might affect patients. Employers don't support mandates for this kind of reason. If a treatment, service, or product is going to improve health, and especially if it's going to bring value by improving health and lowering costs, of course we want to cover it. But broad mandates often don't distinguish. And recommendations from a provider group or a consensus group don't necessarily meet these objectives, nor does a test being FDA approved. Mandates could lead to waste in the healthcare system, and when we waste money on one treatment, that money is no longer available to spend on useful and needed treatments for this particular patient or for others. In conclusion, I would just mention perhaps the most important takeaway from the California analysis of the proposed legislation was that there were many patients who should have gotten biomarker tests and they didn't get them. But the reason was not because insurance companies refused to pay for those tests. It was because the doctors didn't prescribe them. What that demonstrates is a lack of awareness of these tests and a lack of education. And that's something that can and should be addressed, but that a mandate for insurance coverage will not address. Thank you for the opportunity, and I look forward to any questions.
Okay, so we have a few more minutes relative to this topic, and I want to make sure my colleagues have opportunity to ask questions. So if you could raise your hand if you have a question, and unfortunately I don't know all of you because there's some new people here, but Will does. We'll get to you. My first question, Dr. Mark, we're talking about cost, and sometimes as we sat here and heard Tammy share her story, associating costs with someone's life is hard to swallow. How much is your life worth? But you talked about how much a test costs, and now it costs $200. Can you just briefly, succinctly elaborate how you got to that so that we know when we go down this path, it's not trying to figure out you, doctor, aren't doing what you're supposed to be doing because you're not prescribing the test compared to these are new initiatives in trying to help treatment and furthering someone's quality of life.
Absolutely, yes. So the cost of this type of testing is dramatically gone down in the last few years. And comprehensive biomarker testing for oncology, what we call NGS, for example, is just a few $100s now. Believe it or not, sequencing every gene in the body, whole genome sequencing, is even cheaper, which doesn't make sense but on the surface, but believe me, it does technically. That's even cheaper and can be about $200. But the cost savings is not so much in the testing. It's in getting the right patient on the right therapy at the right time. And because of the way cancer tests and the drugs work, we now have many drugs that are approved not based on the type of cancer a patient has, but based on the mutation that's driving that cancer. So, for example, just a few weeks ago, a drug was approved for any cancer patient who has a RET mutation. We don't know if they have a RET mutation unless we do comprehensive biomarker testing. And that's not a singular example. There are half a dozen drugs, and next year there will probably be a dozen, and the next year there will probably be 2 that are specifically approved not based on the type of cancer, but on the mutation the patient has. So if we're not testing every cancer patient for these mutations, we are missing these mutations and missing the opportunity to get them on the right therapy that will dramatically improve their outcomes and allow us to avoid much more costly and toxic therapy for these patients. The idea that these tests are already covered is an interesting one, and I would just add to that. Prior to this legislation being passed here in Louisiana, a great deal of my time was spent arguing with insurance companies on coverage for patients to get guideline-based testing that patients absolutely needed for me to make a treatment decision for how to treat their cancer. After the legislation went into effect, I spend far less time doing that, and I spend far more time treating patients. So,
and in your experience, have you seen widespread providers just not asking for these tests?
No, that's not the case at all. I think providers understand the importance of these tests. Are there singular examples of providers out there who might not be ordering based on the guidelines? Of course. But what we've done in our health system, for example, is we've actually taken the decision to order these tests or not out of the doctor's hands, so they don't even have to worry about this. At the time cancer is diagnosed by the pathologist, we have an automatic system, an algorithm that identifies which patients need the testing and which patients would not benefit from it. So they are automatically tested based on an algorithm that is guideline and scientifically based, so that we don't even have to worry about, are the doctors ordering the right thing, are they ordering something they're not supposed to?
Thank you. Okay,
Sure.
Representative Ferguson.
Thank you, Madam Chair. I guess maybe if you have time to respond to what the Mr. Gelfand said, but is there a difference in the he was talking about being FDA approved
Right.
versus the guideline-based testing? I mean, are you using a different guideline as an oncologist?
Yeah, the absolute gold standard of cancer care the world over is the NCCN guidelines. And a lot of coverage is based on the NCCN guidelines, the National Comprehensive Cancer Network. This is a group of the largest cancer centers in the world, and they all send their top experts to write the guidelines, which really outside of Europe that has their own guidelines, the whole world uses to treat cancer. And so we based our practices off of those guidelines. They don't get any better than that.
But those aren't necessarily, have not gone through the FDA process? Or?
Most of them have, but not necessarily everything in the guidelines are FDA approved. A lot of times FDA approval may lag a little bit from what's based on the guidelines. The guidelines are based on pure scientific evidence, and the FDA approval may come later down the pipe.
Thank you.
Are there any other questions? Paul, you had a question?
The question I ask is, if it's cheaper, what is the challenge for states not using it or having this legislation? There is gotta be one.
What I've been told is that, and this is, I'm not an expert in this, but what I've been told is often insurers are not looking at cost savings over 5 to 10-year periods for cancer patients. They're looking at it over a much shorter period because they don't expect that the cancer patient will remain employed with the same employer, therefore they would be changing plans. And so they want something that might save them money in 6 months rather than a cancer patient living for 5 years and they're going to save money over the 5-year period.
Follow up. So they're not looking for them to live, that's what you're saying?
Yes, that's correct.
Tammy?
Can you hear me if I talk about that?
Yeah.
My cheerleader voice from high school. So my question on this is there a compromise here between, thank you, is there a compromise here between having, for lack of better words, a free-for-all to be able to order a test whenever you want, or to establish guidelines that put in medical necessity and, as was said, medical necessity and accuracy of the test as a compromise between the two?
Absolutely. So I think the legislation, and again, I'm no expert in this, but I think it looked at guideline-based, FDA-approved, and tied to CMS coverage determinations. So, we would not support legislation that would just allow any doctor to order anything at any time. We would want appropriate tests to be ordered. That's, as my colleague said, that would obviously have a benefit towards patients and change the outcome of what we do for patients, which is what biomarkers do.
And Mr. Gelfand, would you agree with that? And first, I want to say, this is the first time I've had actually anybody here from an ERISA plan committee, so thank you for being here, because ERISA plans are the majority of insurers, and anything we do at a state level absolutely does not impact the majority of people. It is incumbent upon the ERISA plan holders to adopt that same sort of legislation, so I can't tell you how grateful I am that you're even at that table. So if you can you answer the question also?
Thanks. I think that from the ERISA plan perspective, we'd be much more interested in looking at tests that were medically necessary and that was included. I think also other things to take into account would be perhaps getting groups like PCORI involved and looking at the comparative effectiveness of using these tests versus not using these tests. That's why we created PCORI in the ACA.
Yep, I would agree with you. I think PCORI would be a great place to bring it from the federal perspective of it, but I'd be interested in understanding how we could develop medically necessary and accurate enough testing to be able to put it through, because there is a cost savings benefit to being able to identify these treatments earlier and not going through the step therapy of 10 different things before we get to something effective. And there's also a quality of life issue beyond just the financial aspect of it. So I know we're not voting on this today, but I think the work that we should be doing is finding that compromise between medically necessary and accurate, and from there, how we can make it work for both. And you were going to say something, ma'am?
Yes, Hillary G. from American Cancer Society Cancer Action Network. I was just going to add that as the legislation is written, there are clear guardrails for both the circumstances under which testing is appropriate. This does not include screening, but this is diagnosis, treatment decisions, and ongoing monitoring. These are all to impact treatment decisions, and then the clear medical and scientific evidence that must be met in order for a test to be covered.
Thank you.
We're going to go take our last question from Senator Lang.
Madam Chair, my question is for Mr. Gelfand. I hope I pronounced the name correctly. If the testimony we heard from the doctors here today is comparable, it's accurate, it's indisputable, it's irrefutable, is it not possible that the markets will force these changes themselves without having a government mandate if in fact it's going to save money now? And as you mentioned, it only really affects the small mom and pop shops because the large self-funded groups are subject to ERISA and they would not fall under these mandates. So if these claims are right, is this something the market would naturally do without the government interfering?
If the kind of savings that were projected in some of the literature I've seen, including in the PowerPoint, were accurate, there's no question that insurance companies and risk plans would on their own demand that these tests all be covered. I think what's happening right now is that they're seeing that some tests are indeed providing savings and are improving care, and those are being covered, and then some that may not be proven yet, and as a result, they may not be covered yet. And so So over time, that will change as more evidence comes out. But yes, we do think that the markets resolve this issue.
Thank you, Senator. Thank you, panelists. As we work through this model, before we get to our next meeting, if any of my colleagues have insights, thoughts, opinions that they would like to forward along to myself and to Will as we work through this model, I would appreciate that. Thank you, panelists, very much. We are going to move on to the discussion on policies that enable value-based payment arrangements for gene therapy. So if we could have those panelists come forward, please. We have J.P. Weisky with the Campaign for Transformative Therapies, Bert Bruce, who is the U.S. President of Rare Disease at Pfizer, and Jesse Lemberger, the Senior Director of Strategic Pricing at Pfizer, and we will be holding our questions until the end. So we're going to start with JP, please.
Good morning, and waiting for the slides to pop up. So I'll start by introducing the organization and what we're talking about here today. So if we go to the next slide, I'll just click it right here.
Can you put the microphone closer, JP, please?
You bet. That's probably the first time I've heard that. I'm usually pretty loud. So I'm with the Campaign for Transformative Therapies. It's a piece of the Council for Affordable Health Coverage. And it is a big coalition with all sides represented. The intent in this discussion is trying to find some ways to pay for these really significant gene therapies that are coming across the pipeline. Talking a little bit about gene therapy, and the folks to my right will probably have more detail on this, but what we're talking about is some transformative treatments, and you obviously won't be able to see the slides. The slides will be available on NCOIL. You can't read those. But these are treatments that fundamentally change the interaction with a patient and their disease state, and have a durable sort of cure, and I know that our members would hate me to say that, but a durable cure for really serious medical conditions. The expectation is that these are going to be quite expensive as we move through. One of the gene therapies we've talked about that is out already, so Zolgensma deals with spinal muscular atrophy. It's expensive, but it is changing the lives of children around that. We're also talking about the next couple that are definitely coming out are related to hemophilia. Those are also likely to be very expensive, but again, sort of change the way people interact. If we look at what's coming, and this is sort of the broad message, so this is the message from the future that everybody needs to pay attention to. There's a ton of gene therapies that are going to be coming out in the next few years, and financing these is going to be a major issue both for private health insurers and through Medicaid, as a matter of course. 63 are expected to be approved by 2030. And that means that there are going to be some significant costs that are going to attach. So when we look at the hemophilia specifically, and this is an example that we're sort of looking at, the question is, if their gene therapy is going to cost $3 million for a patient to get, is there actually value delivered? That question actually has been answered to some degree. ICER looked at this. There's some links there to the whole report if you want to take a look at it, and found that this $3 million gene therapy will not only deliver a much better result for patients, but in the long run may be less expensive. Obviously, the issue here is that it's a $3 million gene therapy and being able to afford it. So one of the things that we do need to talk about is around Medicaid and financing. There are arrangements that are in play, and we were just talking about the issues in private insurance. There are issues around access, how both private and public use access to sort of limit the use of expensive drugs in some cases. The costs are significant as we attach. And then inside Medicaid, there is a requirement to cover all medications. So how do we sort of look at this in a different way and move forward? Again, we're looking at something that's going to transform the way medicine interacts with patients. We're going to be taking people likely off of Medicaid and public assistance into new jobs in some cases, and this explosion is coming. So you need to find some solutions that are balancing access and cost. And what we're talking about from our standpoint when we looked at this is something called value-based payment arrangements. There are a number of names that have been used. They may use different names, outcome-based arrangements, value-based purchasing arrangements. The idea is that you have a shared risk model. It holds manufacturers accountable from the standpoint of a requirement that they have to deliver on the outcomes that they're promising, and the drug has to do what it's supposed to do. But that also means that you broaden the patient access. So these contracts, both privately and publicly, are done on, really a one-on-one basis. If you've seen one contract, you've seen one contract, and that's part of the issue, that this is going to be a costly endeavor for states to get into, and this is something that they need to start planning for now as we see the coming approach. The contracts deal with who gets access to the drugs, what the drug actually costs, what the risk structure is, who the eligible patients are, how the rebates are tracked. All these sort of issues are going to be important. There are a variety of these, and they may get into more. There's, a pure outcomes-based determination, a warranty model. There's some ability for payment over time, installment plans. All these, in addition to having issues surrounding the technicalities, will also have accounting issues that sort of play. I would also note one of the things that you may want to look at and understand as you're looking at the pricing is what you're doing from a reinsurance standpoint. If you've got one plan covering a $3 million gene therapy, whether it's a care management organization or it's in the ACA or something else, that means there's potentially some adverse selection. One of our coworkers worked at a plan that had 24 of the 26 hemophilia patients in the state of Nebraska enrolled in his plan. Needless to say, that plan was not in fact profitable, and there was some adverse selection that was sort of applied as a result. So those issues are going to be increasingly important. So again, as we look at the balancing, what we believe is that using the value-based payment arrangements ensure both broad access and control costs, and as a result, they align the incentives between the manufacturers and the payers and the patients in this front, so that broad interests are represented. I want to note some challenges that are sort of in play as you look at this issue, as you talk to your Medicaid and other folks. The administration of these, again, is a one-on-one administration of the specific drug that attaches. You need to negotiate the specific terms. We just had a call with CMMI this week to talk with them about what we can do to sort of promote these sort of outcomes and these contracting arrangements on a state-by-state basis. So hopefully the federal government will make it a little bit easy. How do you actually measure these outcomes, and what outcomes do you want to go? When we talked to individual state Medicaid, we had some interesting results, and I will tell you that Medicaid offices that are thinking about it are not necessarily thinking about it in the same way. Some want clear clinical data, others only want to use claims data. Third-party evaluation. How do you pay for this third-party evaluation as a piece of it? Where is the trust sort of attaching as a matter of course? And again, operationally, how do you deal with managed care organizations, medical providers, and others? And then you've got the ambiguity over best price. But there are opportunities. And again, we're looking at a opportunity as we get into these that medicine is changing. It's changing for the better. That there's going to be value delivered to patients. There's going to be value delivered, to Medicaid over time. But there is a upfront cost that attaches. And again, we have an opportunity to align these incentives appropriately, broaden the access, risk share, manage those costs, and manage those costs on the basis of outcome and data analytics so you actually know what you're getting, what you're paying for. I would note that it's a number of states from a Medicaid standpoint have already been here. They've already done some of this work, so those are certainly folks that you can take a look at. They're up there on the screen. Again, the slides will be available. And we're looking, I think what we're asking for here is for you to be aware of this issue from our standpoint, to take a look at with your Medicaid and your insurers, to have this discussion up front, and to start looking at policies that make sure that this is a path forward. from that standpoint. I'll finish, and we have a white paper that we did on the VBAs, and there is a QR code there. Anybody who scans a QR code should be able to get a copy of that paper. If you want to send a link, I'll send a link over to Will as well, so folks can get a copy of the paper. With that, I'll hand it over to my colleagues. Thank you.
Thank you, JP. Bert?
All right, good morning. All right, I'm okay. No green light. Good morning, everybody. My name is Bert Bruce. You put the slides up? Thank you. I'm the U.S. President here for Rare Disease, and I'm here with my colleague Jesse Lemberger, a Senior Director in our Strategic Pricing Group. And while JP and I have never met before, it's going to look like we've known each other for a while, because we're going to primarily be here to educate a little bit and talk about some of the exact challenges that we were going to look to be able to face together in being able to bring these transformative therapies. So we really appreciate the opportunity to be here today. We're going to focus in on, I'll do a little bit of education. I'm not a scientist, so I'll try to explain this differently, but to talk a little bit about the different waves of innovation. I think our slides will be available here as well, but if we think about where medicine has gone, we think about gene therapies in what we're calling this third wave of potentially transformational innovation. If you go back years ago to symptomatic treatments, things like aspirin, then there were the next wave of the biologics that were modifying the disease. But as JP talked about, what we're looking at now are fundamental diseases that can change the outcome. Some might use the word cure. Some are not actually designed to cure, but they're designed to be a fundamental change to a disease. And that's a very significant breakthrough in those areas. Now, I'll take a little bit of time just to talk a bit about gene therapy, what it is and what it isn't. Because the first column here talks about the area we're going to spend some time talking about today. It's called gene therapy. Sometimes it's called gene transfer. And what it's doing is taking effectively a gene that is not working properly and replacing that gene with one that is working properly. So it's not changing the underlying biology of who a person is, but it's correcting something that's incorrect and allowing that function to work the way that it was supposed to be designed to. That's different than the middle column, and there's some exciting science that's earlier in this space, which is actually going in and editing a gene and changing the way that a gene is designed. And then there's a third category called gene regulation. Some of those are a little bit earlier, and they are more designed to change an individual's forward-going biology, but that's not what we're going to be talking about today. It's going to be about the first category called gene therapy. We're effectively thinking about it as taking something that is not functioning properly and replacing it with something that is. This simple schematic shows a little bit about how that works. There's something that's called a capsid, and if that sounds like capsule, you can think about it that way. It's an empty container, and you put the properly functioning gene, which is called a transgene, inside of that. The two of those together are called a vector, and then you're able to infuse or deliver that to target organs in the body, most commonly the liver, but there can be other places. And when it arrives, then the capsule dissolves, and the gene, the correct gene, is taken up by the body and replaces. And that's effectively the function of how gene therapy works. There are 7,000 rare diseases. And one of the reasons that there's a lot of promise, and most of the examples that JP was referring to in the pipeline are coming, many of them are in rare diseases, of which 95% do not have any approved therapy. And the vast majority of them are one, there's nothing behavioral, they're genetic, and they mostly affect children, which means they affect parents, which means they affect working parents, which is why we're here today. And so if we think about that frame with so many diseases that don't have a cure, if 60 come by 2030, that means that there'll still be well over 6,000 that still have no cure. And that's one of the promises and the potential is that for very small populations in very targeted ways, that a very big difference can be made in areas where there's significant unmet need. But rather than show you another slide, because I can't envision how many you're going to see over the next couple of days, I'd like to share a short video. And this is about a guy named Riker. and his mom, and you get to see a little bit. He has a disease that's called Duchenne muscular dystrophy, and we'll see a little bit about how this affects their day. So you can see a lot of what's described in this slide in that past video. Duchenne muscular dystrophy is diagnosed usually boys between 3 and 4 years of age, and they start off like most boys. This is a disease, by the way, that's specifically only for boys. So I'm not just choosing the word boys. But then they're not able to keep up with certain milestones, not able to walk as fast, or they may be a little bit more clumsy in gaining their balance. And it's effectively a genetic disorder that eventually removes the body's ability to continue to develop muscle. Now, if you think about what Riker was not able to do, and you think about what Riker was still able to do, you'll see that there was a lot in that video. As boys progress through, they lose the ability eventually to be able to walk by themselves. Riker still had it. He was in what is called the ambulatory phase, where they're still able to move around, but as the disease progresses, they would lose that ability to ambulate. They call that non-ambulatory. So that exercise that he was getting with his mom or with a physical therapist is very, very important for him to be able to delay the progression of the disease for as long as it possibly can be. And there are different costs, obviously, that are going to be associated with that age. And so the earlier that a boy like Riker would be able to have a disease that could arrest the disease from progressing any further or change the course of that disease, perhaps a significant breakthrough for himself. Now, if you look at Duchenne muscular dystrophy, like many, many, many other states, there are, every state has boys that are affected, but every state doesn't need to have, nor do they have, a treatment center for the disease. So there are 35, according to the patient-parent muscular dystrophy, there are 33 Duchenne centers that are certified in 21 states. And so what does that mean? Just like most children's hospitals, 90% of which treat children that come from out of state, the same is true for Duchenne. So whether you're a state that has a certified center, and these centers provide phenomenal care, or you're a state that does not, that simply means that boys in your state and their parents would travel to one of these centers. But therein lies some of the challenges and the opportunities we have to talk about, as JP talked about. Should and if a product comes to market here, then there has to be an opportunity for the states to work together and for us to work with the states to be able to ensure that access is available. If access is not available, then that can create delays in time for the boys to have access to the medicine. And you can imagine in a disease like this that every day is very, very valuable. And so that's part of the reason why we're here, is to be able to start the conversation around what are the pathways that we'd be able to pursue together to ensure that when diseases are available, or I'm sorry, when medicines are available for this disease, that patients and their parents have access to those medicines as quickly as they possibly can. Right now, there are about 28 states that have the capacity to treat these patients. And what we're doing, and JP actually, he references as well, is states that have to sometimes apply to get permission to enter these innovative agreements. And so that's a very important permission that we want to talk about, because it allows us to be able to think about what type of value-based agreement, what type of model is appropriate. Is it the same for a hemophilia patient as it would be for a Duchenne patient, as it would be for a different type of patient? And we see here that CMS has already approved these types of special protocol agreements, the ability to sit down and have these conversations with over 13 states. And there are some, including Louisiana, where that is pending. And those asks have been made to allow us to be able to come to the table. Oklahoma, another example. And so sometimes it overlaps where we're looking to get care, and sometimes it does not. But what all of these are going to require is the ability for us to be able to partner together, to be able to understand how we can create new pathways, define what those pathways are for individual diseases as we look to bring forward these breakthrough medicines to the patients who need them. So thank you for the opportunity today, and we look forward to your questions.
Jesse? Oh, okay. So do we have any questions from my colleagues?
I guess my question is we talk about these are coming in the future. Do we have any of these gene therapies that are being utilized now? And what treatments?
Yeah, I mean, Zolgensma is one that's fairly common, and I think the hemophilia is expected to get approval both for hemophilia A and hemophilia B, I believe, this coming year, maybe as soon as in the next few months. And so those will be out, and that means once those are priced, that's going to be a significant cost driver, and so getting ready is the key.
So the states that put this in, was there legislation passed, or did their health departments just work with CMS on their own to do it?
So just to clarify, the products are covered. Zolgensma has 3 publicly available innovative agreements in the market. CMS had to approve the waivers before the negotiation could take place. Okay. So all the other states actually cover Zolgensma without an innovative agreement.
So but the agreements, were they just negotiated with CMS on their own, or did the legislature get involved?
Yes. And I say yes because it varies state to state.
Okay.
Some states require, their Medicaid is required to go to the legislature to get formal approval. Okay. In other states, they're allowed to negotiate the agreement on behalf of the state and can negotiate directly to do the state plan amendment. There are also other drugs outside of the gene therapies that are in the protocol as well, things that are more population-based in some cases. So some of those agreements exist, and they're continuing to work through those. But there are options. In our paper, we discuss the states that have used it, and we have some sample state plan amendments available, and the states that need legislative, and that we believe need legislative, and the states that can negotiate directly.
Thank you.
You bet.
Representative Ferguson?
Thank you, Madam Chair. I have a question. If, say, a person has a gene therapy for something that is curable, are they then still able to pass that gene on when they have children, or does it correct it completely for when they have children? Would they also still be subject to the same disease, even though that person's cured?
Yeah, so the examples that we're talking about today, it does not change. So it wouldn't affect one way or the other what happens between generations. So you're not changing that ability to pass it on for the good or for the detriment. It's only affecting that individual for their lifetime. Now, the other side of that is because you are introducing a one-time therapy that is going into the muscle or going into, in this case, target the muscle, but going for a specific disease, it's not like if one doesn't work, you can flip over to a different one. And so oftentimes, the patients and their parents that are making decisions, even to participate in these clinical trials, are making a one-time decision for their life. And so that means that the selection process is going to be important. Some products are intended to be for every individual who has a disease. Others are not. Others are intended for a subset because of the severity of the disease and what the potential benefit could be.
Could I ask another question? Have you got other people? I guess I'm trying to understand this quality payment. So say they have gene therapy for hemophilia or something, and then the patient's not cured, then the pharma would pay 80% back or something if the patient continued to need treatment and really wasn't cured. Is that how I understand the program?
Right. They would negotiate those agreements based on specific metrics, the specific drug, the specific, what they're promising, how it sort of works. So those are going to vary on agreement to agreement. If you're looking at something that obviously costs $3 million, you're expecting that is on a patient-by-patient basis. In other cases, if for therapies that are a little bit lower cost, not necessarily gene therapies, those are on a population basis. So for example, there's a heart attack drug, and they measure the number of people who have a second heart attack over time. There are others that are looking at whether or not individuals are on ventilators. There's some that are looking at whether or not, quite frankly, the patient survives after the first year, and then different measures after the second year. So there are some variations, but the agreements really are, the state plan amendment allows the negotiation broadly, right? And then individually, drugs are negotiated between either the insurer or the Medicaid agency for what they're measuring and who's measuring it and how they're tracking it.
Thank you.
Yes.
Thank you. As far as the treatment, how quickly is it effective? How long does it last? And I expect it depends by person, but just generally. I mean, let's say there's a treatment for this young guy. What would that do for him?
Obviously, we don't have clinical data, but
Well, let me see, what realistically do you think it would do for him?
realistically, it would slow the progression. The clinical trial is looking at slowing the progression, so we would hope that it would hold his current status steady for the foreseeable future. Obviously, that's a reason to try to treat as young as possible. So now there are patients out there who are 8, 9, 10, 11, but eventually we'd be hoping to treat patients right as they're diagnosed or soon after they're diagnosed to hold their treatment as long
So
as
it won't
possible.
reverse?
It will not. This type of therapy will not reverse the disease entirely, but we're hoping that it would slow the progression for many years.
And the treatment, just an idea, is it an injection?
It's an infusion, so you would go into the...
And how often?
Once. It's a one-time
Just one
therapy.
time, and that's supposed to do it?
Yeah.
Yeah, and just to use the hemophilia example, as I understand it, they're going to be measuring how much factor you have to use, how much factor you need to do, and reduction comes relatively quickly, and the hope is, within a certain period of time that it may not be eliminated, but the risk levels drop precipitously for the hemophiliac as time moves on.
We have 2 more questions, then we need to move on. If we can go to Representative Naccio, please, and then Senator McClendon to close.
So if I'm hearing you correctly, then these treatments are not going to reverse the disease, so somebody will still incur health care costs going forward, just hopefully at a minimum level? Okay, and then from the cost share perspective of this, are you assuming whether it's Medicaid or private insurance, there's going to be a limitation of stop loss or reinsurance or carve-out because a $3+ million claim on any one individual policy is going to increase rates for every other every other member significantly? And that's also going to max out their lifetime out-of-pocket max, which is then going to also incur more costs going forward for the rest of the members of that policy.
You can go. So one of the issues is going to be, to your point, you're going to have, when any one of these gene therapies come on, depending on the size of the population that's impacted. Most of them are small, but any one that comes into play, you may have a large number up front. And the hope is that you have lower costs as time goes on, as that normalizes, as the access to that treatment goes on over time. And so there is an upfront sort of issue. But to your point, I think that's one of the things that I think may need to be discussed from an access standpoint, is how you pay for a significant gene therapy and concern about public-private crowd-out issues that individuals. And again, to pick on Medicaid, if your care management organizations, one's covering it and one is not, you're going to have adverse selection. You're going to have issues potentially with individuals who are, employed and maybe to get access to it will go through Medicaid in order to get access to the treatment because it's that important. So that's, I think, a concern. On the flip side, I think most of these diseases are that we're talking about are rare diseases that are significantly debilitating. And so as a result, they're probably already on Medicaid, and there are real possibilities, again, depending on what it is, that they go off Medicaid. And so that the costs drop, not only for their treatment, but as well as other social welfare programs, as a piece of it, that they're able to have better lives and in some cases able to work in ways that they couldn't before.
So you just said something that always makes me uncomfortable when we start talking about insurance legislation in benefits like this, is we hope that it's going to. So how long before you think your industry would have more definitive than hope for a $3+ million product in future healthcare costs?
Yeah, I think if you look at the therapy by therapy, right? So I think it's a therapy by therapy issue that you need to look at. So I think if you look at the example, I cited the 2 gene therapies for the ICER report. They clearly found value. They clearly found it was durable. Once those are approved, those are going to be changing lives and cutting costs, I think, over time significantly, with obviously significant upfront costs. So I think there's that's one. And I think there's going to be varying success and varying issues. Some will, like you talked about, delay the progression of certain diseases so they're not as debilitating over time. Others, be closer to curative. So it's going to vary depending on gene therapy to gene therapy, and I think it has to be looked at on a one-off basis, from a coverage standpoint.
Yeah, no, I have to agree completely with JP, and I think we'll all agree that hope can be a dangerous word and it can be a powerful word, and you're 100% correct in both. Patients and parents are hoping that these medicines will bring the benefit. We will know 5 and 10 years later much more than we will know when we bring the products out, to what extent they're able to deliver on that benefit. And the alternatives are part of the equation, as JP is talking about. Just to use the 2 that we've talked about today, if we're talking about hemophilia patients today have access to many different types of medicines. They may not be curative, but they're expected to live a normal lifespan. They incur cost over that lifespan, but they live a normal lifespan. Little buddy Riker here is not going to live to 30 under probably any circumstance, and the costs are going to become more significant over that period of time. And there are no other alternatives. So what we would be looking at to be able to have those discussions is what would be appropriate to be able to think about how to provide access to a boy like Riker. And what about a boy that's 5 years older than Riker? It's going to be a difficult discussion to have to understand what is that value for different people at different times, given different alternatives. But that's why the encouragement that we want to have is to be able to come to the table, to be able to have those specific conversations, whether you're going to be the state who would be receiving those boys or the state who will be getting a phone call from other states because you're treating them. So I appreciate your question. They are difficult challenges, and that's why we're here to start the conversation. Thank you.
Senator, if we could, we have to keep moving, JP, I'm sorry. So Senator, if we could get your question and then we can move forward.
Thank you, Madam Chairman. When the price is negotiated, did you say it's negotiated with the manufacturer or is it through a PBM?
It's the manufacturer typically, directly, and the agreements are fairly in the ones that are available. You may know better, but they're negotiated on a one-on-one basis, and they're looking specifically at what the outcomes are. So again, while you're saying hope, the idea is that if the outcomes are not matching what the cost is, that there's a rebate attaching. You're obviously expecting that it's going to hit that, but they're negotiated with the manufacturer.
So just to specifically answer, PBMs are on the pharmacy benefit, and these are on the medical benefit. These are delivered through outpatient hospitals. So we typically do not go through a PBM for these types of products.
Do you look for it to stay that way?
Do I look forward to staying it that way? Yes. We would prefer to negotiate directly with the health insurers.
And is the pricing on an individual case basis, or is it per disease pricing? Say, the example you gave, is that pricing that family pays, another family that has the same symptoms, will it be a different pricing?
So the product is dosed by weight, so there are some technical limitations to delivering the exact same price to every patient. We hope to overcome those limitations and provide the same price per patient, but some of those things are out of our control.
And one more, does location play a part in it, where they live?
Where they live will only matter whether they have to travel out of state to get therapy. Oh, the price? No, the price would not matter where they live.
Thank you.
Thank you. Thank you to our panelists today. This has been a great discussion. If we could get the next group of panelists coming forward, we are going to continue our discussion on the gold card laws and prior authorization reform efforts. In the healthcare context, a gold card is something that is issued to healthcare providers upon meeting certain conditions, typically quality metrics that allows them to bypass certain prior authorization requirements. We did have a general session on gold cards at our annual meeting in Scottsdale last November, which focused on the Texas gold card law that has recently been signed into law. Gold card bill was introduced here in Louisiana this year, but it was ultimately changed to be a piece of broader prior authorization reform legislation. Both those pieces of legislation can be found in your binder starting on page 36, also on the website and the conference app. Today's session is meant to serve as a follow-up to the Scottsdale session so we can learn a little bit more about gold carding and the thought process that led to the Louisiana bill change. So today we're joined by Jeff Drozda. I apologize if I pronounced your name incorrectly. He is the CEO of the Louisiana Association of Health Plans. Mariah Bowen, VP of Governmental Affairs at the Louisiana State Medical Society, and Miranda Mater, our Senior VP of Policy Affairs at AHIP. So if we could get the conversation started, please, Jeff.
Good morning, Madam Chair and members of the committee. Jeff Drozda, Louisiana Association of Health Plans. And once again, I want to thank Tom and Will for the invite for us to have this discussion, because I'm sure if you have not seen prior authorization or gold card legislation in your state yet, you will. And I just want to mention a couple things about prior authorization. And, there are significant benefits to it. However, from the provider side, which I think, we'll hear from, is that it definitely needs some significant improvement in terms of fraud, waste, and abuse, in terms of inappropriate use of high-cost care. Employers ask us to do what we can to keep the cost of premiums down. And prior authorization is one way that we do this. Even CMS uses prior authorization for outpatient services, DME, and other sorts of services. So to talk about the Texas legislation, I know that you've heard a little bit about this beforehand, but just October 1st, they finally came out with their rules after a year after passage in 2021. And looking through the comments, over 100 pages of comments talking about the complexities, the confusion on both parts, the plans and the providers. So this brings us to what we saw in Louisiana with regard to gold carding prior authorization. And it was sponsored by Senator Robert Mills. And, but before he introduced it, he had a full head of hair, and I don't know what happened to Senator Mills, but this is what gold carding could do to you. I do want to thank him publicly because it's his leadership that turned a bill that was a one-size-fit-all bill into a bill where both parties came to the table and say, you know what, let's work together. Let's really force the health plans to come up with a program that we can implement in the next year. So Senator Mills took that Texas bill, whittled it down into a two-page bill. And if you're looking for gold card legislation in your state, if you're looking for model legislation, strongly encourage you to look at Senator Mills's bill because I think it avoided the pitfalls that happened in Texas and some of the other places around the country. So, in a nutshell, I mean, the bill directs the health plans to come up with a program excluding pharmacy services and says you need to file that plan with the Department of Insurance in a form that will be developed by the Department of Insurance, and then after that certain date, the program will be implemented. So it's very, very simple, but it does put, I think it forces both parties to come to the table and say, what can we do that's best for the patient? And that's the number one goal for I think, all parties involved. So I'll stop there and be happy to answer any questions at the appropriate time.
Mariah?
Absolutely. Is this on? I'm sorry, I can't tell whether it's on or not. No? Go. Did that work? Great. Okay, if I can borrow your, I have a presentation as well. Thank you. Again, I'm Mariah Bowen. I'm with the Louisiana State Medical Society. Thank you for having me. We appreciate the opportunity to be here, and welcome to Louisiana. Go Tigers. I didn't think I was going to get to say that this year, but yay. As Jeff sort of alluded to, I am the Physician Trade Association. I think all of you have a society or a medical association in your state, so you're probably familiar with who we are and what we do on behalf of physicians. Unless I have physicians on the panel or physicians behind me, a lot of times I tell people physicians are not good physician advocates. They are very good patient advocates, but they do not do a very good job of advocating on behalf of themselves or on behalf of the practice of medicine a lot of times. That is because they are very frequently in clinic, in hospitals, 24/7 jobs. It's hard for them to rearrange their schedules. So I'm going to try to do justice, but again, I invite you, if you are a physician, to feel free to chime in. My pictures, in case you have an interest, are all architectural elements from the Louisiana State Capitol. I'm going to start with turning the machine off, clearly. There we go. Let's try again. No. Here we go. Okay, so I think many of you have likely seen a lot of these graphs and charts that are provided by the American Medical Association. Just what I would like to reiterate to you is that from a physician perspective, it's the patients who are receiving or attempting to receive the medical benefit, right? But they're also the ones who are the victims of delayed care. And if you look at every one of these graphs that I've provided for you, they clearly show that from a physician outlook, patient care is delayed. 93% of those would report some delay, and you can see by the graphs that they are significant in certain circumstances. 34% of physicians report that delayed care has serious adverse effects on medical care. So the impact on the physician office and their practice is equally challenging. If you look at what we're talking about in that second little bubble, 2 days in a physician's life is spent on prior authorization. Some of the facts that are available at the top are from the Physicians Foundation. That's a great survey that just came out this past week that you may want to look at, and I can send all these links to Will if anybody would like to receive them. Keep in mind that physicians do work 7 days a week. Patients do need medical care 7 days a week. Getting prior authorization does not always happen 7 days a week. Again, this is a challenge in the physician community that we look to overcome. So, back in 2018, a group of national organizations convened. They developed a consensus statement to improve prior authorization. That as well I can make available if you have not seen copies of it. Those are the groups that were involved. These are the 5 reform categories that were addressed. Yet, here we are in 2021, and while we've made these consensus statement and seemingly agreed to a number of different things, most of my physician providers would tell you that it's not much better. Now, Jeff stole some of my thunder related to the Louisiana piece of legislation that we had, but just to give you an idea of why Senator Mills helped us with this, I have to take my glasses off to actually read. That's a little backwards, but forgive me. This is from a physician in his district. The physician was requesting a prior approval to insert a spinal cord stimulator into a patient with spinal cord damage. The request was for imaging of the lower back in order that the physician could appropriately place the wire to stimulate the spinal cord. The request for imaging was denied. This is the denial. Your records show that your doctor needs imaging to assess your spinal cord. Your entire spinal cord should be visible on neck and upper back studies. Lumbar spine or your lower back pictures would only be needed if your doctor knows or suspects that your spinal cord extends into your lumbar spine. Even me with a non-medical background can tell you that that's a bit ridiculous, right? But this is what they get every day. These are the types of reports that I hear from physicians. It's ludicrous at best. And when they go to overcome some of these denials, keep in mind that they are inserting themselves into a contract that they are not a party to. The contract that is being discussed is between the patient and the health insurer. So they're already in a predicament. But they will also tell you that it's very easy for someone to deny them, where it may be more difficult for someone to look in the face of a patient and say no. And yet on the other side of it, does a patient always understand what is needed or why they are asking for those services? So there are a lot of challenges when we start talking in medical terminology. And as Jeff said, this is what we started with, the original bill. Some of the outlines are there. Excuse me, the amended bill is really, I think, kind of clever. It gives the opportunity for the health insurers to be very creative in what they come forward with to help us try and alleviate some of the challenges that we face with prior authorization. We are looking forward to seeing what those look like. And I will say, just in conclusion, everybody asks me what we're going to do next. I don't know. I work for a board of directors. I have a council that I have to answer to, much like you. We have to vote on those things. So right now we are watching the Texas rulemaking. We're watching what's happening both with federal legislation and rulemaking. We're waiting to see what happens July 2023 with plans that are filed with the Department of Insurance. And our follow-up discussion on any legislation next year will not occur until January. So those are kind of our talking points, and I've given you the AMA fixpriorauth.org. It is a great resource if you've not looked at it. It has the opportunity for patients, physicians, consumers, and employers to provide stories on prior authorization if they have those to share. And I would just encourage you as legislators to please reach out to your physician community. Obviously, Senator Mills did discuss what was happening in his community with a number of physicians. Reach out to them, talk to your employers. There are also statistics that show a great deal of employer impact when an employee is awaiting health care services. And a lot of that is related to denials for prior authorization. So that's it. Thank you so much for having me.
Thank you so much. Miranda?
Yes, a waiver.
You want this one?
Is that on? It's on. Thank you. I apologize, Chairwoman. Thank you, Madam Chairwoman, and members of this committee for the opportunity to continue the conversation around prior authorization and gold carding. I was here back in November of last year, where I did have the opportunity to sit alongside of the Texas Hospital Association and the Texas Medical Association to talk about the Texas bill at that time, to talk about the concerns and the challenges that we saw with that law, but quite frankly also spent a lot of time talking about options, talking about alternatives to things like one-size-fits-all sort of blanket checks for providers. But we spent time talking about electronic prior authorization and how that really can be significant for providers to do just what Mariah talked about earlier in terms of reducing administrative burden for them. Our recent statistics even tell us that doctors today continue to manually submit at a 60% rate prior authorization submissions. And even in the pharmacy space, which is largely electronic, they're still doing so at around 38%. So when you think about electronic submission, those are the types of things that can really give providers faster time to decision, faster time for patient care. It can significantly reduce administrative burden, and it actually provides them a lot more information we found through that survey and those results that I shared back in November of 2021. In March of this year, I had another opportunity to present before NCOIL to talk about, again, another kind of opportunity that really sits in front of providers as they think about trying to reduce administrative burden. And the time I spent here was focused on how providers can do so by taking on financial risk for the decisions, the medical decisions that they make, for coverage issues, by entering into value-based relationships. And we heard the prior panel talk about that, certainly in the context of drugs and gene therapy, but that is a significant way that providers can look to either waive or reduce significantly prior authorization. So here today, I have the privilege and opportunity to share really briefly some high-level survey results from a gold carding program survey that we asked our plans to share. And we did so really in further of this consensus statement that Maria mentioned earlier that health plans entered into with hospitals, with physicians, with pharmacists back in 2018. And as part of, I think, one of the documents that you have in front of you, it really lists with quite a description the work that health plans have been doing in furtherance of that consensus document. Further targeting the types of services that are subjected to prior authorization, providing the availability of automation for providers in their offices to take advantage of electronic platforms so that they don't have to 60% of the time submit these prior authorizations manually. In addition to regular reviews of our prior authorization, both the systems and the services that we require prior authorization, using input directly from providers to make sure that those are still consistent with evidence-based clinical guidelines that will ensure quality care and then will protect patients. And then lastly, continuing to waive in certain instances those prior authorizations when needed. So, I wanted to just make sure that the results that I share with you today is in furtherance of that 2018 commitment. We've been really striving to work with providers on the ground to get this work done so that we can, again, continue to improve, as Jeff talked about, improved the process, improve potentially, the administrative burden that we know providers feel, but again, do so in a way that doesn't jeopardize or risk quality of care for patients, patient safety,
and at the same time make sure that we also are not jeopardizing affordability. I would also just reiterate before I move into quickly the results, the issue that Jeff did raise. You know, purchasers of health care, and I know I've talked about this before, whether it's employers fully insured, whether it's the self-insured employers, I know we heard from James earlier, whether it's the federal government through Medicare and certainly through Medicaid, all of these purchasers are looking to and demanding ways to ensure affordability of care, to reduce fraud, waste, and abuse, and to ultimately make sure that patient safety and quality of care is preserved. And all of these purchasers, again, are using prior authorizations and demanding that. So let me get into the survey results. You, again, have another one-pager, hopefully in your packets, that go to these top-line survey results. There are 6 of them. So top line is that gold carding programs have increased since 2020. Gold carding programs are most effective when they are used selectively, so not one size fits all, and that they are continually evaluated. So there is regular review of the provider, regular review of the decisions that they made, making sure that they are connected to and aligned with evidence-based quality standards. So that's the top line. The sort of 6 findings underneath of that is, as I said, gold carding programs today are being used more frequently. So if in 2019, around 32% of plans were using those. Today, around 58% of plans are using those. The second finding is that gold carding programs work better for some services than they do for others. 73% of plans reported that gold carding programs work better where there is a clear and a consistent clinical standard for that service. So for example, things like high-tech imaging, cardio services, elective inpatient medical services, orthopedic services, those are all places where there is clear and consistent clinical standards where gold carding programs can be effective. Number 3, gold carding programs include those providers where there is a sufficient prior authorization volume. So in other words, you can actually look and test and measure, and that they also have a low denial rate and a high approval rate. That's really important. Number
Miranda,
4.
We are right at our time, and I know that the findings are in our booklet, so we unfortunately have to keep moving. We're going to go to Senator Mills for comment, and we could maybe take one question, but we have to conclude. I apologize, Miranda.
Thank you, ma'am. And really just thank you all 3 for presenting today. And it's a work in process in Louisiana. But for the other legislators in the room, I was surprised at how much pent-up frustration there was with the medical doctors and the physicians and the providers when we did speak with them. And they, as hard as they work, they're not necessarily that good at getting out in the public and letting you know what their problems are. So Mariah has a full-time job trying to represent them and get that voice out, and they're generally underrepresented. We need 10 Mariahs out there to properly represent them because Jeff and his comrades are so good at what they do. We started 5 miles apart. We got maybe a mile apart towards the end. We're making some progress, and I do appreciate the work on this. It's important. And prior authorization, we don't have a good handle on it yet, but we're making progress. We've got to keep working. And I would suggest we're, like I said, just maybe 1 or 2 steps further along, but we're not there yet.
Thank you. Thank you. Okay. So seeing that we have no questions, we are going.
Miranda's report was not in my book.
Oh, the findings can be found on the app or the website. So
Yes.
Thank
And
you.
if you have any questions, happy to answer them.
On the app or website, look for the findings. So there's no other business in front of the committee. I would like to take a motion for adjournment, please. Second? All in favor? Okay, we need to move right to our next presentation, so 5-minute break, and don't forget to sign in and get your CE credits. Thank you.